It's a real honor to be here. Thank you to the organizers for having me. And consider yourselves all invited to our first Canadian CTO meeting, which will be in Toronto this fall. These are my relevant disclosures. So I work in East Toronto, and this is a typical patient that we have, 61-year-old refugee who's had angina for years, initially not looked after. You can see her medication list, extensive. Her echocardiogram demonstrates normal LV function, and she has significant LED ischemia on myocardial perfusion imaging. So I'll let the initial angiogram cycle through for you. Our setup is radial femoral, 7 French femoral, 6 French radial. It's a left dominant system, obviously, so if we need to go retrograde, we're going to be using a ping pong system. And we have wires in the first septal and also in the circumflex. And you can see through these views that the LED feels retrograde quite well, but the proximal cap is clearly ambiguous. Seems like a relatively short CTO, not particularly calcified, but within a segment of approximately 2 centimeters, we don't know where the proximal cap is. The impact of proximal cap ambiguity on our success and failure can't be understated. So this is data from the Progress CTO registry, which demonstrates that if you have prox cap ambiguity, you are dealing with more complex lesions, you have a lower rate of procedural success, and a higher utilization of higher risk techniques and complications. So it's not entirely surprising that with the new global CTO algorithm, resolving proximal cap ambiguity with IVUS is front and center and one of the earlier considerations that you need to have when you're planning your procedure. So this is my colleague, Chris Lee, who's working on the left there. And what we're doing is we have the IVUS down into the first septal, and we'll do a pullback from the first septal. So what we're looking for initially is a change in caliber of the vessel. So you can see the proximal cap of the LED coming in there, and suddenly the vessel is much larger. So we know we've switched from the septal into the main vessel. And this is an offline measurement just to demonstrate to you how small the septal is. And there we're coming through the region of the proximal cap. And just proximal to that, the vessel is much larger. So if you miss that proximal cap, just look for the change in vessel caliber size and then scan forward. The next step is to leave your IVUS in place of the proximal cap and take multiple views. So you need to be able to correlate with this with your angiographic work. And typically we're going to want multiple views when we're entering or crossing the lesion. So you've marked your proximal cap. This is probably less important if you're doing live IVUS guided wiring, but I'll show you in this particular case, once we've done the IVUS, you can see here that the septal is ischemic, and we had to dilate that to continue. So we did not think that this was a favorable case for live IVUS-guided puncturing, but we had our views and our position. We began with a turnpike spiral Taliflex microcatheter with a Gaia third next wire, and you can see the wire just sliding down into the septal repeatedly. So we're often initially going to tapered, non-jacketed wires. The second approach here is to use a supercross 120-degree angulated microcatheter, which gives us perhaps a better opportunity at directing towards the proximal cap than a straight microcatheter. So here we are in position with a 14-gram tapered non-jacketed wire, the Warrior. And we were clearly not in the right space. And this is the only place the supercross would engage. So the final option for me is to bring in a dual lumen microcatheter. The advantage of this is that I think it really provides the best possible support when you're sliding up and down a side branch. You can position it very well and really direct the force of the wire into the proximal cap. The downside of the dual lumen microcatheter is you can't advance it and follow through into the lesion and de-escalate, and it can be challenging to trap it out. So you have to be quite careful to not lose that proximal wire position. So here we felt that we were successful angiographically, and we decided to proceed with wiring using the dual lumen as the primary support without de-escalating. We will almost never use a jacketed wire to enter the proximal cap in this context because it'll simply just slide into the side branch repeatedly. And you can see us here using the opportunity as stated previously whenever you inject wire. You'll see that in the next view. So this is our IVUS pullback from the LAD once we've crossed to get a sense of whether we've been subintimal at all. And you can see here the wire coming in from the septal at about 7 o'clock, demonstrating that although our entry point was slightly eccentric into the proximal cap, it's intraplaque wiring and then obviously true lumen distally throughout. So this is just an offline example of how we can do measurements with this particular IVUS system to plan our procedure. I cannot understate the importance of continuing to use your IVUS catheter throughout the case. As we all know, there's plenty of data, most recently from the Renovate study, which demonstrates that the use of IVUS in complex PCI improves outcomes. And I think if we're going to do these cases, we have to give our lesions and patients the best possible chance of success. So this system, the ACIST system, you have to take off. I take off my glove and I do hand measurements. I find that very facile and easy to negotiate. And here we're identifying the distal vessel size and plaque burden. We actually have 2 different HD IVUS systems in our lab, and we use both relatively easily. I would say the image quality is very similar for both. It's simply the ergonomics that you prefer in terms of how you measure. Speed of pullback for the ACIST can be up to 10 millimeters per second. So here's our stent placement. We've chosen a 12 and 38 millimeter everolimus eluting stents, 3.0 and 3.5 respectively, and we're deploying those. And of course, at the end, we have to check our stent result. So it's not acceptable just to put it in. We have to finalize and ensure that we have adequate lumen. So despite the fact here that we're osteally greater than 30% plaque burden, I would say we have a pretty good result with excellent stent expansion over 7 millimeters squared at the ostomy of the LAD. So that is not likely to cause us problems in the future. And then we can scan forward and identify where we think the minimal stent areas are here proximally. We have an MSA over 7 millimeters squared. And we'll check the vessel distally as well. The benefit of using high definition images is really, you can actually see dissection. So we didn't use a ton of IVUS in the non-HD era, and when I go backwards, I simply cannot interpret. So here you can be quite confident that there's no dissection at the distal edge, and that's the final result on this vessel. I'd like to show you one brief example of live IVUS wiring as a complement to what we just showed you in our case in a box. So this is another LAD with an ambiguous proximal cap, but this time we have a large diagonal branch which will facilitate IVUS. And I'm pointing out the proximal cap here and a pullback from the diagonal. And here we've left the IVUS in place, and we are using a turnpike spiral microcatheter again and a high tip load wire to enter. And the pullback demonstrates that the wire position is acceptable within the lesion, and then we can advance the microcatheter, de-escalate the wire to a safer wire, and wire beyond that. So just a subtle difference. And that's the final result there. So I hope I've taken you step by step through how we do IVUS-guided proximal cap puncture. It's an extremely important technique. I think amongst all the other techniques like retrograde, ADR, et cetera, this is a necessary tool in the toolbox for a complex CTO operator. Thank you very much for your attention.
Great.